I really appreciate that I can speak about sepsis-associated hemoadsorption or sepsis-associated rhabdomyolysis and hemoabsorption therapy. Is this topic relevant and timely? That is my first question. And if we look into the literature, we can find more than 11,000 publications on rhabdomyolysis. The first publication was in 1948, and this year, in April, we had 172 publications, and during the last 4 months, it is doubled. So rhabdomyolysis is a very common state condition in the intensive care units also, and in every other ward. So it is a common and widespread disease or condition. I looked into the data, treatment of rhabdomyolysis using hemoadsorption, and I found 354 publications, and if I focused on cytosorb, I found 27 publications, and this year we have already 6 new publications in this topic, so it's relevant and timely, we can conclude. I looked into the cytosorb literature database, and I found many publications, many case reports, and 3 randomized controlled studies also. So we can tell that these 3 RCTs published during the last 3 years indicate that we have to deal with this problem. Rhabdomyolysis is a serious syndrome due to direct or indirect muscle injury leading to the release of muscle fiber contents into the bloodstream, mainly creatine phosphokinase and myoglobin. This will result in a classic triad of syndromes: muscle pain, muscle weakness, and the reddish-brown urine. It's a cola-like urine we will see. What are the triggers? Crash syndrome, excessive physical activity, or permanent immobilization also can lead to rhabdomyolysis. Major surgery, burn, electric shock, hypothermia, metabolic, endocrine, and genetic disorders, electrolyte imbalances, delirium, alcohol, drugs, toxins, and some psychiatric syndromes, malignant hyperthermia, malignant neuroleptic syndrome, serotonin syndrome, and compartment syndrome, infection, and dysregulated immune response that I don't call sepsis because it's dysregulated immune response to infection. What is the proposed mechanism of rhabdomyolysis in sepsis? Direct muscle invasion by the pathogens, toxin generation by the pathogens, cytokine-mediated muscle cell damage can occur, and muscle ischemia due to shock. So we have to treat all of these aspects to treat rhabdomyolysis appropriately. It's an interesting study I found. They searched for the most common pathogens causing rhabdomyolysis, and they found many pathogens, many bacteria we fight against day by day. For example, Streptococcus pneumoniae, Pseudomonas aeruginosa, Acinetobacter baumannii, and the most common focus of rhabdomyolysis-inducing sepsis was pneumonia with a high mortality rate. And it's quite interesting because it tells me that we have to aware and prepared if we see this kind of microbiological results and patients with pneumonia. We have to screen regularly them, and we have to act promptly to prevent the results of rhabdomyolysis. What happens during rhabdomyolysis? Due to the muscle cell breakdown, myoglobin goes into the bloodstream. It is precipitated and degraded in the urine, and it causes occlusion of the tubuli of the kidneys. resulting acute tubular necrosis. And moreover, due to the leakage, the capillary leakage, and volume depletion, renal vasoconstriction occurs that enhances these problems. If we see the CPK and myoglobin kinetics, we can conclude that rhabdomyolysis occurs when CPK reaches this 1,000 units per liters, and if it increases and creatinine increases, we will see acute kidney injury. But not only myoglobin is the problem with this process, but the DAMPs that are released into the bloodstream due to the dysregulated immune response. There are many cells, many inflammatory and pro-inflammatory cytokines, chemokines, and the complement cascade that contributes in the course of acute kidney injury and rhabdomyolysis. And as rhabdomyolysis induces this immune response enhances rhabdomyolysis. So it's a positive feedback problem. And acute kidney injury is very common in rhabdomyolysis patients. The incidence is 10 to 40%, and rhabdomyolysis is responsible for 15% of acute kidney injury. This was a quite interesting study. Patients were randomized into control group and to that was a conservative treatment, and kidney replacement group. They received different types of continuous renal replacement therapy, and they found that the mortality was extremely high in patients who required renal replacement therapy. So maybe they got a delayed treatment, and that's why they died. What are the goals of our therapy? We have to recognize and treat the underlying pathology. It's the main message, first of all. And we have to diagnose early this problem. We have to correct the electrolyte disorders. We have to monitor the patients. We have to give appropriate fluid therapy. And we have to prevent further organ damage by eliminating myoglobin and to try to rebalance the dysregulated immune response. The conservative therapy works if the patient has not acute kidney injury, but in case of AKI, it's not enough. Continuous hemodialysis is effective. It's really effective in terms of myoglobin elimination. But if it's effective, where is the place for hemoadsorption? Why should we initiate hemoadsorptive therapy? When and for whom? In this study, patients were randomized into CRRT group and the CRRT with adjunctive hemoadsorption therapy with cytosorb, and they found the patient population there was no significant difference between the two groups, but they found that cytosorb really effectively eliminated myoglobin, and it was effective. The severity of acute kidney injury was decreased by using cytosorb. This is a quite new publication. It's a case report of a 3-year-old girl with viral infection associated with rhabdomyolysis. Authors measured the concentration of myoglobin and CPK pre- and post-adsorber every 2 hours. And if they see that the removal rate decreased, they changed the adsorber. And in this scenario, they could treat this little girl appropriately. This is our case, and I won't go deep into the entire case because we will hear about this patient later. So this is a She was a 38 years old female with Streptococcus pyogenes infection and necrotizing fasciitis. And we decided on cytosorb therapy, and we did similar as in the earlier case. We measured CPK, PCT, and we tried to measure myoglobin. It was above the measurable limit that our machine can measure. So we measured CPK and PCT 3 hourly, and as you see, as the adsorber saturated, we changed it, and after another 12 hours, our patient CPK elevation stopped. So maybe we have to establish a protocolized measurement for pre- and post-adsorber levels. It is a key, I think so. You know, cytosorb adsorbs every molecule between 10 to 60 kilodalton molecular weight. So it's obvious that it adsorbs proteins just like myoglobin. It adsorbs the pro-inflammatory cytokines, the DAMPs, and fortunately it doesn't adsorb albumin. So it was a question in the morning, what about albumin? So I think cytosorb is a good thing to preserve the albumin levels of our patients. So cytosorb has the potential to rebalance the dysregulated immune response. But CPK is above the adsorption limit. Why do we see decrease in CPK levels when we use hemoadsorption? Maybe it's due to the attenuation of hyperinflammation and not the direct absorption of this molecule. So it seems cytosorb effectively attenuates hyperinflammation. And in this study, it was found also that when patients were treated with adjunctive hemoadsorption, interleukin-6 PCT levels decreased significantly, while they achieved stable hemodynamics by using cytosorb. So it significantly reduces the levels of interleukin-6 PCT and may contribute to hemodynamic stabilization. And we know that every hour in shock increases mortality, so shock reversal time decreasing effect is good for us. This was a study from Hauchar, Fatima, from Szeged. They pooled data from 33 trials, and they found that using cytosorb, they achieved significantly more stable hemodynamics and shortened shock reversal time. So how can hemoadsorption and cytosorb help us in this problem? In case of rhabdomyolysis, myoglobinemia, a dysregulated immune response due to the infection and also due to myoglobinemia can occur, leading to a shock. And if we use cytosorb, we can treat myoglobinemia, prevent ECI, stop this pathway, this positive feedback pathway, and dysregulated immune response, if we can manage it, it will stop further muscle damage, and that's the same for shock also. So when should we initiate this treatment? I don't know, but it seems that the earlier the better. If we see the signs of rhabdomyolysis, we have some cutoff parameters, CPK above 1,000 units per liter or myoglobin is above 10,000 nanogram per milliliters, and we have to measure and assess our treatment until these parameters decrease beyond the safety limit. Thank you for attention.